Hello and welcome to Lecture 17. We're moving on now to talk about another widely used and legal drug in the world, which is nicotine, primarily consumed by smoking cigarettes or vaping or chewing tobacco, etc. I'm going to talk first about some nicotine epidemiology, talk about why this is such a potential problem. This is one of the three most widely used psychoactive drugs in the world, along with alcohol and caffeine. Because of tobacco use, this is the most preventable cause of disease and premature death in the world. It causes more death than homicides, alcohol, car accidents, and AIDS deaths combined. We are doing pretty well in reducing tobacco use. Current use fell from about 50% in the 60s to around 25% in 1998. I think we're down to about 12% in the United States for tobacco. We'll talk about vaping and its popularity and what a problem that is towards the end. The average starting age for people is declining. 9 out of 10 people are addicted by age 21. So generally what we're talking about is a problem of young people starting to smoke or starting to use e-cigarettes. And you can see a dramatic surge in e-cigarette use in high school students from 2013 to 2015, more than tripled in use. And so 20% of high school students report e-cigarette use. And these are just as addictive as tobacco because it's the nicotine that's the addictive substance. And we're still waiting to figure out what the health effects or potential health effects of vaping are. So, in terms of the history of nicotine, no society that has adopted tobacco has ever stopped using tobacco. This is the only drug abuse that is native to the Americas. Given to Columbus when he landed in San Salvador in 1492. Another thing we can blame Columbus for. And one of the things to keep in mind about a number of sort of natural drugs of use and abuse is oftentimes the amount of nicotine in naturally occurring tobacco is fairly low and probably was far less addictive compared to the manufactured tobacco we have today. It's kind of the difference between chewing a coca leaf and using refined cocaine. They're very different substances, and so that's something to keep in mind. So, tobacco was introduced by Jean Nicot to the Western world, who imported them from Portugal to Paris in 1550 and started actively promoting its medicinal use. Within decades of that, the plant had made its way around England and then to Virginia and other New World locales. The rest, as we say, is history. Nicotine was isolated in the 1800s. Formula was established in 1843. So we start getting an understanding of exactly what is in tobacco that is making its use so popular and why it's having such an effect. So that's a quick introduction to the history. Let's get to the pharmacokinetics of nicotine. Nicotine was separated out from tobacco in 1828. It's one of about 4,000 compounds released by burning. It's a colorless, volatile liquid alkaloid, which is not well absorbed from the digestive tract, although children do poison themselves each year from eating tobacco, but that's oftentimes from exposure to the pesticides on the tobacco. So that's something to keep in mind about tobacco use as well, is oftentimes it's treated with pesticides. The amount of nicotine actually delivered depends on how a cigarette is smoked. So when we talk about the pharmacokinetics of nicotine, it's often very difficult because it depends on the type of cigarette and how the cigarette itself is smoked. So when an individual is smoking a cigarette, they inhale the cigarette at a certain rate, they hold the smoke in at a certain amount, and tobacco users, in particular smokers, are very good at precisely regulating the amount of nicotine they absorb. Many smokers know that when they smoke a different brand of cigarettes, oftentimes they'll get dizzy because it's a higher nicotine content. So nicotine is metabolized by the hepatic enzyme cytochrome P2A6, and importantly, it's important to keep in mind that it can be inhibited by some SSRI antidepressants. So this may increase the clearance time of nicotine in individuals on that particular antidepressant. So in terms of the nicotine yield of most cigarettes, it has increased over the years by a pretty significant percentage. And in fact, the amount of nicotine in menthol cigarettes is higher, and we're going to talk about the problem with menthol cigarettes here in a moment. So nicotine is absorbed from every site on or in the body. In terms of cigarettes, cigarettes are flue-cured tobacco, which makes acidic smoke. That reduces absorption from the mouth, but allows it to be inhaled from the lungs. So the nicotine is absorbed primarily by the lungs. Nicotine is suspended in the cigarette smoke in form of minute particles, which are those tars that we always hear so much about. It's quickly absorbed into the bloodstream from the lungs, and so it has a pretty rapid effect. Remember, in the earlier lectures, we talked about how inhalation is one of the fastest routes of administration for psychoactive drugs. So pipe and cigar tobacco are air-cured, and so they actually make alkaline smoke, and that nicotine is absorbed from the mouth and then does not need to be inhaled, which is why you don't inhale pipe or cigar tobacco. You simply bring it into the mouth, as it were. And of course, chewing tobacco is also that sort of alkaline substance and is simply absorbed through the mucous membranes in the mouth. Pardon me. So nicotine is quickly and thoroughly distributed, goes to the body, brain, placenta, all bodily fluids, including breast milk. So it's everywhere. Most of this is metabolized out by the kidneys before it's excreted, by the liver before it's excreted by the kidneys. Elimination half-life is about 2 hours, depending, and we'll talk a little bit about how this can be affected by other drugs, around 2 hours. So that's generally why you get smokers wanting a cigarette every couple hours, certainly who are chronic smokers, because they've lost about half the dose of their cigarette, so they're trying to reintroduce it again, so it's pretty close, pretty short half-life. For smokers, you can detect carbon monoxide in their breath for hours after a cigarette. So in my research, we actually used a carbon monoxide breathalyzer to determine whether or not our participants had been smoking in the last 24 hours. One other note, the major metabolite of nicotine is contanine. This is how urine analysis is done to determine if someone has been smoking. Generally, that's done in laboratory settings like research settings, but insurance companies oftentimes provide a discount for people who don't smoke, and I believe some may be requiring those urine tests, and certainly some employers may be as well. When I worked with the state of South Carolina, we had to certify that we weren't smokers or our insurance rates were higher, and that's because smoking is such a health risk that smokers cost the system more money. So menthol cigarettes are very different. They're not just flavoring tobacco. They're actually present in about 90% of all tobacco products. So menthol actually decreases nicotine's ability to activate the nicotine acetylcholine receptor. Currently there is some proposals to ban menthol in both the European Union and the United States, because smokers of menthol cigarettes are far less likely to quit and are far more likely to relapse. And they actually develop more nicotine receptors in the reward pathway. And so because they develop these increased nicotine receptors, menthol cigarettes are much more addictive because of that. And so we probably need to think carefully about this particular addition. I don't think it's an accident that menthol is in most cigarettes, and menthol cigarettes are more addictive. And so we really want to keep thinking about whether or not to allow menthol cigarettes. So how does nicotine activate the brain? Well, it's involved an indirect activation of the sympathetic nervous system. So it occupies and activates nicotinic cholinergic sites. So at low doses, it will stimulate those receptors. High doses, it will block those receptors. So there are some paradoxes about tobacco use, and we call it Nesbitt's paradox, which we'll talk about in a minute. So it can cause the release of both dopamine, which is probably its reinforcing properties. Certainly it activates the nucleus accumbens, but also has effects on acetylcholine and glutamate, which is why it might have effects on memory. In some of the research I've been involved with, we found that people who are withdrawing from nicotine use have substantially reduced memory performance 24 hours following their last cigarette. So we need to think carefully about that mechanism. We also know that nicotine has effects on GABA. And so we're going to have to figure out more about this as we start to understand the neuroscience involved here. So there has been some questions about nicotinic-derived drugs potentially helping to treat dementia. And so far that has not led anywhere. It certainly has been tried to be used to treat just regular cognitive aging. The problem with nicotine, and we're going to talk about this here in just a moment, is that for nicotine-naive patients, nicotine tends to be very aversive. It makes people dizzy, it makes them nauseous, and so it's not a particularly pleasant way to treat somebody's memory problems. So these nicotinic acetylcholine receptors have a number of receptor subunits, and you can read more about this, but essentially they initiate a series of electrical and chemical signals that trigger the release of dopamine. And one of those, designated alpha-4, appears to be critical in the development of nicotine addiction. So we have to think about potentially thinking about that alpha-4 receptor as an important component of treating nicotine addiction. So in terms of the pharmacological effects of nicotine, initially causes nausea and vomiting by stimulating the vomiting center in the brain and sensory endings in the stomach. So nicotine-naive patients, as I said a moment ago, it can induce nausea and vomiting. When I was growing up, the way parents got their kids to not smoke is when they caught them smoking, they made them smoke an entire cigarette. And then they got super sick and never wanted to do it again. So the other pharmacological effects include stimulating the hypothalamus, which produces an antidiuretic hormone, and this causes fluid retention. So people who smoke also retain fluid. It does reduce activity coming in from the muscles by blocking some of those receptors, or it activates that sympathetic nervous system response, or blocking the sympathetic nervous system, which produces relaxation. It does increase your heart rate, your blood pressure. It also contracts your blood vessels. And the carbon monoxide in smoke combines with oxygen better than hemoglobin, so it actually decreases the oxygen carrying capacity, so it actually suffocates your cells. So there are a number of effects of smoking, some of which are related to the contents of cigarette smoke, some of which are related to the nicotine itself. And so we want to really be mindful of these, and we really need to, this is an important global health crisis. So the other pharmacological effects is it constricts the blood vessels in your skin, which produces cold, thin skin. It also causes wrinkles. That is, you will age much faster from smoking, and you can actually go online and look at some smoking-induced aging. Also inhibits stomach secretions and stimulates your bowel. May increase your metabolism of fat. There is certainly a problem with people who quit smoking gaining weight, and this seems to be particularly troublesome for women who are trying to quit smoking. They seem to be bothered by it more. It's not that they gain more weight, it's just a societal thing. The other thing that smoking will do is it will dull your taste buds. Most of that's because of the smoke. Will slow your stomach contractions, can increase your blood sugar, putting you at more risk for diabetes. It may improve attention and memory. There's certainly some lore about this. In fact, I've heard of college students using nicotine gum during finals week. I don't recommend that at all. Because at higher doses you can get nervousness, tremors, panic attacks, and nobody needs that during finals week. And it may have an antidepressant effect, and this is an important question about whether or not smokers might be self-medicating. Certainly it has some anxiety relieving components. Certainly nervous people who smoke sometimes get calmed by it, although it technically should be anxiogenic. That is, it should actually increase anxiety. So, and that gets us right here at Nesbitt's paradox. So nicotine causes arousal and release of epinephrine, which really is a stress response. Most people say it relaxes them. So this has to be relevant to the reason why people smoke. The first question is it just that it's relief from withdrawal, so it's negative reinforcement? Or does it depend on the stress of the situation? That is, it relaxes people who are under high stress, but stimulates them when they are under low stress. And certainly, there is a lot of lore in people in stressful situations in the military, etc., that feel like they do better in those stressful situations if they're allowed to smoke. And I don't know, there's not good data on that, but it's certainly part of the lore. Smokers report subjective effects if nicotine is given by smoking or intravenously, but non-smokers don't. And so part of this may be tolerance. Part of it may be that people who smoke are more likely to have a different genotype. And so all of these are important questions to think about. So that gets us to the problems with smoking. First off we'll talk about some toxicity and dependence. Heart disease is a major problem. Nicotine increases the workload on the heart because it reduces oxygen supply by introducing carbon monoxide, but also your lungs don't function as well, so it makes your heart work harder. Makes it more likely for you to develop arteriosclerosis, which can block arteries, and also thrombosis or clotting. So people who smoke are at much greater risk for clots. This is greatly increased if you're taking oral contraceptives, particularly thrombosis. Women who take oral contraceptives and smoke have very significant increase of heart problems. So that's a very dangerous thing to combine. And so keep that in mind. Most prominently, of course, we know about lung disease. My father died of lung cancer. He was a heavy smoker. Those ash and tars deposited on the membranes clogs up those. It actually causes oxidative stress in the lungs, and so is a clear carcinogen. Even without lung cancer, can cause emphysema later on because of just the overall damage to those tissues. So in addition to the increase of lung cancer, mouth and bladder cancer also increase, and these are also greatly increased by alcohol. So if you combine smoking with alcohol, which is very common. And then keep in mind that lung cancer occurs in less than 10% of non-smokers. Probably a lot of those people have been around smokers. In terms of reproduction, cigarette smoking reduces oxygen delivery to a fetus, decreases fertility, produces more stillbirths, smaller babies, premature babies, sick babies, and may increase the risk for sudden infant death syndrome. And so certainly pregnant mothers should not smoke, in addition to not drinking alcohol. Smoking is particularly damaging to a developing fetus. So in terms of tolerance or dependence, there's little biological tolerance. Smokers usually dose themselves within very, very consistent amounts in a very narrow range. We know people go through significant withdrawal symptoms. The time course of those depends on the symptom itself. The sort of irritability, anxiety, difficulty concentrating, restlessness, weight gain, and insomnia, all of these take time to resolve. The irritability and anxiety should resolve within a couple of days. The difficulty concentrating and insomnia may take longer, and certainly the weight gain is going to be a longer-term situation. We do know that long-term nicotine causes an alteration in the GABA systems in the hippocampus. Because nicotine inhibits GABA, removal of nicotine during withdrawal causes increased GABA activation. It's one of the things we talked about in terms of up and down regulation. So GABA is upregulated during nicotine use. That is, there's an increase in those GABA systems. They're more sensitive. And so when you take away that nicotine, those GABAergic neurons are far more active. So we actually have shown in some of my research that heavy smokers show marked reductions in memory performance following 24 hours of abstinence. In fact, about a 40 to 50% reduction. And we believe that's because of that increased GABA activation without the presence of nicotine. And we also have shown in the most recent paper in 2012 that there may be sex differences in withdrawal. That is, men and women may have differential responses to withdrawal, in particular their memory performance. And so always keep in mind, any of these issues are often individual. So when we talk about, well, this person is weak because they couldn't quit cigarettes, no, it's also entirely possible that they have different genotype, that it might be related to their sex, etc. So always be mindful of that. So when we quit smoking, within minutes, your body starts to recover. 20 minutes, your blood pressure can return to normal and your heartbeat will stabilize. Within 8 hours, your PO2 will increase, the amount of oxygen in your blood. You'll start to clear out some mucus from your lungs. Within 48 hours, you can actually taste and smell again. And your chances of a heart attack decrease. And then over the months, all of this improvement you can get. So within a year, your risk of dying of a heart attack is cut in half. Within 5 years, stroke risk is back to that of a non-smoker. And then 10 years later, your chance of getting lung cancer is now cut in half. So how do we get people to quit smoking? Well, first thing is low content, nicotine content cigarettes are not useful. People just smoke more of them. In terms of nicotine substitution or replacement, there's some success with these. The problem is mimicking the dosage. That's the problem people often have, is the ability to get the amount of nicotine right that they were getting in their cigarettes. And so that can be problematic. There are some efforts to reduce craving, so antidepressants like bupropion, which is either Zyban or Wellbutrin. It's all the same thing. I will talk about that more in a moment. All replacement methods are equally effective, and they approximately double the quit rate of smokers without help. And so these are things to think about. There are a couple of drugs that I think are worth thinking about. Certainly the bupropion or Zyban, as well as varenicline or Chantix. So about 90% of smokers stop without help. But consider which is the most relevant factor. Is it a pharmacological addiction? There are sensory motor factors involved, the cognitive effects of withdrawals, the social factors involved. One of the things we've seen over time is because you can't smoke anywhere, there are fewer and fewer smokers. In fact, the behavioral economics of this indicate that as you increase the taxes on cigarettes, people will smoke less. As you decrease the social availability of smoking, people smoke less. So I currently live in Fort Collins, Colorado, and the entire downtown corridor is a non-smoking area. So you can't even smoke outside the bar down there. So factors that create the addiction, about 85 to 90% of cigarette smokers consider themselves addicted to nicotine. One of the biggest problems is its rapid and frequent reinforcement. About 200 times per pack, it reinforces that behavior. The rapid metabolism allows frequent and repeated use, plus that rapid onset of withdrawal. So oftentimes it's just mitigating that withdrawal factor. There are also very complex direct pharmacological effects. There are also social rewards of smoking in a peer group. And smoking is often conditioned to other activities. Eating, drinking, driving, particularly drinking and driving. Those are oftentimes places where people will smoke more, particularly drinking. People will oftentimes report they only smoke when they've been out drinking, or other people like smoking when they're on a long car ride. They say it helps keep them awake and attentive. So some more factors are that there's really no performance impairment. This is not like drinking or doing other drugs. It's not impairing your ability to do your job or to drive or do anything else. In fact, there may be an improvement in alertness. In fact, we see improvements in reaction time in people who have nicotine. Well, relatively inexpensive, but that expense is getting greater and greater. And particularly if you think about the amount of cigarettes consumed, it's getting to be an expensive habit. You don't have really any equipment. It doesn't require anything other than, something to light it with. Readily available in most convenience stores, although that's certainly reducing over time as well. Fewer and fewer retailers are selling cigarettes, and in fact, a number of retailers, I believe both Walgreens and CVS, have indicated that they will not sell to anyone under the age of 21, which is an interesting component. And of course, cigarettes are portable, easy to store, as are the vaping equipment. And currently, it's legal for people 18 and up to smoke. For now, there is a move in Congress to change that to 21, and a number of jurisdictions, I believe, have changed it to 21 already. So how do we treat nicotine dependence? Well, certainly nicotine replacement therapy is one potential treatment. So that includes gums, patches, inhalers. Bupropion, which is Wellbutrin or Zyban, is another potential component. Again, that seems to reduce cravings. And then finally, the partial nicotinic receptor agonist varenicline, or Chantix, appears to be particularly effective for most people. Now, we'll talk more about this later on when we get to pharmacogenetics. But one of the problems with varenicline is there is a genotype for which this particular drug does not work. And it has to do with the nicotinic receptors themselves. We believe those are also the more hardened smokers. That is, this genotype also seems to be more susceptible to addiction to nicotine. And so it's a good drug of choice if you can go along with it. The great thing about varenicline is that you can smoke while you start it, and then you just simply taper off. People report wanting cigarettes less and less. I know a number of people that have been successful in stopping smoking that way. So in conjunction with pharmacotherapies, it's good to have a specific quit date. There's no substantial social or occupational dysfunction. You don't need an intervention for this. So there are effective over-the-counter treatments. Nicotine replacement is available over the counter. So you can start this right away. Chantix and Zyban you'll have to go to your doctor for, but if you're going to quit smoking, your doctor is going to be on board. So working with your doctor is a good way to go about that. But definitely having a specific quit date is effective. So how do we assess dependence? Well, first we can just ask how many cigarettes do you smoke per day. In my research, we use the Fagerstrom test of nicotine dependence. Score of which is less than 3 is low to no nicotine dependence. Greater than 6 is highly dependent. You can also assess nicotine and continine levels in blood, saliva, and urine. And you can determine that nicotine use sort of within hours these ways. So continine effects reflect tobacco use in the last 7 days. So it's a really effective way to assess nicotine use. In terms of carbon breath analysis, in the last few hours, it generally stays higher in chronic smokers, particularly if they've recently smoked. So nicotine replacement therapies can be used as a first-line treatment. There are 5 FDA-approved nicotine replacement therapies: the patch, gum, lozenge, nasal spray, and inhaler. Again, the difficulty is matching that dosage, so you kind of have to, with the patches, which people often find effective, you might have to cut them. And in fact, one of the best things to do as you try to step down is to sort of reduce the size of that patch every day. We're going to talk here in just a moment about e-cigarettes or vaping. It doesn't seem to be a very effective way to get people to quit smoking. So they quit smoking and start vaping. You can combine nicotine replacement therapies with each other or with bupropion. I'll talk about bupropion next because it's, I think, a particularly effective strategy. But you can start on your own quitting smoking with nicotine replacement therapy. Bupropion or Zyban is another first-line treatment. We'll target that dose at about 300 milligrams a day. Start at 150 milligrams per day, 7 days prior to a quit date. After 3 to 4 days, increase the dose to 300 milligrams. And then get to that quit date on the 7th day. Side effects include insomnia, some GI symptoms, jitteriness, potentially seizures, and these should not be used in those with eating disorders. That's another important thing to keep in mind. But it does have particular efficacy in getting people to quit smoking. Varenicline or Chantix, this is, for my opinion, one of the best treatments because it's relatively short in terms of how long you would be taking varenicline. This is a unique monoamine oxidase. It's a monoamine. It's a partial agonist at the nicotinic acetylcholine receptors, and it blocks the ability of nicotine to stimulate the acetylcholine receptors and thus blocks the activation of dopamine. And so what it does is it essentially gets rid of dopamine as a reward for smoking. And so essentially this is an extinction trial. And if you remember back when you took intro psychology, and you think about how animals are trained and you stop rewarding a behavior, that behavior will extinguish. So it actually is very effective. The elimination half-life of varenicline is 24 hours, so it can be dosed once a day. And by allowing people to continue smoking, what they find is it's less and less rewarding, and then the rest of it is kind of gross. And so people find that they don't want to smoke at all anymore. So you want to dose after meals with a full glass of water. The recommended dosage is 1 milligram twice daily, following a 1-week titration. So days 1 through 3, about a half milligram per day, and then days 4 through 7, half a milligram twice a day. And then days 8 through the end of the use of Chantix, 1 milligram twice a day. Course of treatment is about 12 weeks, so 3 months, plus another 12 weeks of continuing abstinence. The most common side effect is nausea, but it does appear particularly effective in treating nicotine dependence. So we're going to take a look at that data here on the next trial. So it is a little bit complicated regimen, getting up to the dose that we want, but if you look at varenicline versus bupropion versus placebo, they're both more effective than placebo, but certainly for weeks 9 through 12, 45% of people are continuously abstinent. By weeks 9 through 24, 30%, and then still about 20% abstinent after weeks 9 through 52. Whereas with placebo, we're not even at 20% in the first 9 weeks, and we're down to about 10% in weeks 9 through 15. So if we look at different dosing regimens, you can see 1 milligram twice a day seems to be the most effective, whereas a half milligram seems to not be sufficient. And Chantix is more effective in general with sort of overlapping error bars here in study 5. So really it's going to be an individual difference, and whichever one works best for you is probably the way to go. That gets us to e-cigarettes. So a principal component of drug treatment is what we call harm reduction. This is going to come up in a number of different areas. So we sort of provide resources to reduce the harm from drug use and abuse. So a real simple example is needle exchanges to try to keep people who use injection drugs from contracting hepatitis or HIV. So e-cigarettes have been shown to be less harmful than traditional cigarettes, but they're still more harmful than quitting altogether. And we're just now getting a handle on exactly what the health effects might be, but the studies have shown high oxidative stress on the lung tissue, and that's where we start to think about things like lung cancer. The chemical components of vaping can be potentially harmful. The other problem is the dose is much lower, so often experienced smokers inhale up to 200 times more with e-cigarettes than they did with traditional cigarettes. So while it may be better than smoking, it's not as good as quitting. And I think that's the important message, is that while it's not as noxious or obnoxious as smoking, it's still kind of obnoxious if you ask me, but it is still more harmful than not smoking altogether. So here's the thing. There's little evidence that e-cigarettes reduces nicotine use in adults. And the problem we have right now is e-cigarette use in kids. So from 2017 to 2018, e-cigarette use increased 78% among high school students, 48% among middle school students. These are kids, and we're also seeing an increase in conventional cigarette use because of that. So if you look at 2012, 3% of 12th graders reported using an e-cigarette, and we're now at 22% in 12th grade. 7% of 8th graders are vaping. So the FDA is moving to limit flavored vaping liquids and flavored cigarettes because these are clearly marketed to kids. They're marketed with candy flavors, cotton candy, cherry flavors, and it's very clear that this has been a concerted effort by this industry to addict kids. And so this is something we need to really think about. So we also have to keep in mind that some vaping devices contain a more addictive form of nicotine. And this is, again, a concentrated effort by an industry to get people addicted to another form of nicotine. So while it may be less harmful than smoking, it's something we need to really think about. All right, so that's our introduction to nicotine and how it affects the body and its pharmacokinetics and pharmacodynamics. I think up next we're talking about cocaine and amphetamines.